And this is a topic, and this is the thing which really worries the most obstetricians. And this whole talk is about how not to too much worry about it, and tell about what are the recent things that we are doing. First of all, I need to tell you that internationally, previously used to be called as obstetric brachial plexus palsy. Now they have said the name has to change. It's changed as to birth brachial plexus palsy, because it's so that the other names always blame the obstetrician, because it can happen due to other reasons also. That's the point number one. And it's a disastrous injury because tremendous amount of psychological trauma to the whole family, and they keep on thinking it's maybe a lifelong disability. And they form a special group because at the time of birth, most of the patients, they blame the obstetricians. The first question they ask us is that, is there any problem which has gone? And we got a very standard answer. We got to say why it is not so. And prognosis is the next question is the problem. I always say when we treat the children, we treat the parents so much. So how about the incidents? One of the important things that obstetricians need to know and to answer is that though there are no incidents in the correct exact incidents in the Indian literature, abroad it's about 2 per 1,000 live births. At Ganga Hospital, we have Ganga Women's Center, where we took her 1,000 consecutive pregnancies we took. And analyze, and there's also the same thing happens. We had two pregnancies we had. But you able to hear me, sir? Okay.
Sir, sorry to interrupt you, sir.
Yeah. Are you able to hear me?
Sir.
Hello.
Please continue, sir.
We can hear.
Okay, I thought some noise came around. Right. Okay. And the other point which you need to think about, is it reducing? So it's not reducing because it's not got any relations to the standard of obstetric care which is found in any hospital. And even in developed countries, even in the United States, in all the Western countries in Europe, the incidence is the same, and almost it has been the same for about the last 1 decade. It's been the same. It has not changed. So that's the next point which we all know. And the mechanism of occurrence, all of you know as shoulder dystocia. And there's a great difference between what happens, birth palsy happening in a child, and that what happens when the fellow falls from a motorcycle. So what happens in a child? Is it's a low velocity injury. It's a low velocity injury, and what really happens is there are 5 nerves that go to the brachial plexus. The C5 and C6, because of the anatomical position, they are more possibly involved, and they go to the shoulder, and this goes to the elbow, and C7 is to the wrist, and C8 and T1 are go to the hands. So these are the 2 things which are most involved, and very rarely all of it can be involved. Okay, all of it. The natural history is that this again is a very comforting factor. If you take the total number of children who suffer, 80% of the infants show satisfactory recovery. I think that's the next point we have to know. And only infants, what is the thing which you'll know whether they'll have satisfactory recovery? In the first 4 to 6 weeks, if the child flexes the elbow, that means you can tell that this child will totally be all right. I think this is one good indication to say. If the child is able to flex the elbow, that means not that the child goes up and the elbow falls down. That is not this thing. It falls by gravity. The child, when it's lying down, if it bends, that means it's fine. Okay, that's good. So what are the current concepts of care? I think it stems up from the last few years of where we do about 250 brachial plexus related surgeries in children. And we have moved from a position where we offered only physiotherapy and watchful expectancy to a stage where useful interventions are possible. I think that's what I would like to say. Basically, it's because it's a low velocity injury. In adults, it's a high velocity injury. When he falls from a motorbike, a high velocity injury. And in all the adults get what is called as an avulsion injuries, whereas all children get what is called as a ruptures. So what's the difference between rupture and avulsion? See, this is the spinal cord, the spinal root comes. Rupture is one where injury happens extraforaminally. I think this is what is called as a rupture. And this I put it in a diagrammatic way. So it comes out of the foramen. the nerve gets injured here. Whereas the avulsion means, the nerve gets ruptured from the spinal cord. It gets avulsed from the spinal cord. So if it happens like this, we can't do anything because we can go inside and then put it back. But whereas because it's extra foraminal, then what happens if we get a good root, then we can take off all the bad things and then put a nerve graft. Here, you cannot. You can do some other surgery only done, and then you can't directly, not possible. And the second point is they get injured, low velocity. There only small gap is there. Okay, small gap is there. So quite possibly they could, they could the axons could go back and then re-innervate. I think that's possible. But then the problem that happens is when they go and re-innervate, exactly the fibers don't go and exactly meet the corresponding tube. They don't match. Okay, sometimes the motor fibers may go into sensory. The fibers that go for biceps, they go for triceps. So this sort of an axonal mismatch happens. I think that's the point happens. So that what results that is called a phenomenon happens what is called as a co-contraction. Co-contraction means, to put it simply, suppose if somebody has to flex the elbow, then what happens? The biceps must contract. At the same time that the triceps has to relax. Otherwise, you cannot get the biceps cannot contract. But because the same way, how it happens in our body is that if the C5 C6 is responsible for this, you will find the motor nerve 7 8 will be responsible for this. Like this, it is like a innervation is nicely arranged naturally. But now in brachial plexus injury, the fibers go here and there. So the fibers which are destined for biceps may go for triceps. But the brain says biceps to contract. So triceps also contracts. So biceps and triceps both contract. Then what happens? It becomes a tug of war, so that the elbow does not again move. So this is the next problem that you find. That's the other aspect which we are now. So in a child, the problems that a child has got is because of muscle imbalance, because some muscles work, some muscles don't work. The problem of co-contractions because muscles working together, antagonist muscles working together, and this is the superimposed on growth. So you'll find that the hand will grow well if only you will find that you will grow well, that if only all the muscles are acting on the bones. Otherwise, the hand will become small. So this is superimposed on growth. So these are the three problems which we have. So now, what has made the change? I think why we say there is a lot of hope for these children is because of the microsurgical capability of nerve reconstruction. And secondly, we understood the pathophysiology of the deformity, why these deformities happen. I think that again we have understood. That's the two reasons why it has changed. And the most important people whom we really love to talk are obstetricians and to the next group is the pediatricians and to the physiotherapists, because you only can make the difference in the lives of these children. You see, for this child, it's a 6 months old baby. This is the standard upper brachial plexus. See, the hand, the left hand is fine. You see the right side, the hand is working, the fingers are moving, but the shoulder and the elbow are not moving. So this becomes, after 6 months, when we explore this child, you will find that the roots are one side are there, and the other side, you will find the other nerves are there, and you will find a lot of mass. This is the nerve mass. This is mass. So that's how we find. These the roots are here, 5 and 6. Okay, this is 6 is really we are not able to get the good root. 5 is good, and here is the anterior and posterior division, suprascapular nerve. So that goes in. So what we do is that we excise that mass. I think this mass has been excised. You see that the roots are here, and the other end, the nerves are over here. So what we do is we take the sural nerve from the leg, we take the sural nerve and then bridge them. Okay, now we bridge them in microscope. We use see these from the roots, and they are all adjusted. They are all bridged. Okay, so they are bridged, and then we also use a glue. We use the 10-0 nylon is what is used in the microscope. That's how it looks. There are a lot of like graphs, like cables. We put a lot of cables. So if you put it figuratively, the neuroma is removed, and then you plug in a lot of cables. You plug in. And the same child, 4 years after the surgery. The same child now is 4 years after the surgery. He's got good recovery. So they are able to do well. So that means we need to spot them at a time when it is possible for us to do. Suppose you see them a little later. I think what do we do at the later, and you find the roots are ours. They got a good hand. Okay, we got a good hand. So that means, the CAT1, the lower roots are fine, the upper roots are not fine. So that means, the biceps is not acting. What they found by a lot of work, research, you get the median nerve and ulnar nerve are supplying the hand, correct? So those two are working. But then there's muscle between the biceps and brachialis, those muscles are all not working. So the median nerve and ulnar nerve pass this way. So what we do, we take one fascicle of the median nerve and one fascicle of the ulnar nerve, and then join it to the nerve of the biceps and brachialis. Okay, that's. But you may wonder, if you take this, what will happen to the hand? Nothing happens to the hand because we are taking one small fascicle, and there are so many cross connections when the nerves go from here to there. So literally, no problem happens at all. So this is exactly what we do. You transfer a fascicle of the median or ulnar nerve to biceps and brachialis. See, like this, you take the biceps and then you attach it. So here you will find one nerve, and then take a small fascicle and a microscope we attach to the nerve to the biceps we attach. Here it's good because the amount of distance they have to travel is also very small. Okay, only this they have to travel. So after we attach a nerve, it takes about 3 to 4 weeks to start growing. And after that, it grows at a rate of 1 millimeter per day. And in a child, this requires only about a couple of months, and then they could start buying. You see this child, we see a child at 1 year, 2 months, the hand is good. Okay, there's no biceps. They're trying so hard to lift it. There's no biceps is present. And what we do for the same child, we do that. We take a couple of nerve transfers. We do. We want to do something for the shoulder. So we take the nerve to trapezius. That's the spinal accessory nerve we take, and it is already given some branches to the trapezius. So trapezius doesn't go off anyway. So after giving a few branches, we take the trapezius, the nerve to trapezius, and we attach it to the suprascapular nerve. That supplies to supraspinatus, some shoulder muscles it supplies. So some amount of abduction they can get. And in addition, what we do, again we do the transfer. Same type of one fascicle at this level doesn't matter. So we do in the neck and we do in the arm. And there's the same results at 4 months. Same fellow who was trying to very hard to find, and now you see he flexes and takes it. So that again is possible. So he is able to take it and able to use it. See, he bends the elbow. Okay, and there's the same boy. So now they're able to hold it up. The shoulder is fine. He is able to bend the elbow. So that's not possible. The same boy, we are following it up 2 years, and it comes at 4 years, and it goes. So this again is the great advances that we could make. So we can get a functional hand after birth palsy by timely care, appropriate physiotherapy, and timely surgical intervention. I think that's very important. Nerve surgeries can be done only up to about one year of age, and 1 to 1 year, 2 months. If the child has got totally no hand, that means that child has to be operated early. That child has to be operated very, very early. So when the child is born, what do we do? I think that's the question. You need to rule out the other cause of paralysis. You reassure the parents, and you need to relieve their anxiety. And we tell them, you treat like a normal baby. We tell them this child's brain is good, heart is good. We really, make them feel very good. And they tell them, you conduct all functions, you do the immunization, do everything, so that you should make them leave very happy. And the question, when should the child be seen by us? An experienced or any brachial plexus team, they should be seen by 3 months. There's no need to send the child immediately. I think as soon as the child is born, you don't have to really send them. There are certain follow-up points. This is what is called as a Horner's sign. You see a child which has got a smaller eye after this, that means they got a major injury. So we follow up by seeing about a lot of clinical signs. And what are the good indicators how you could speak to the patients is if you have incomplete palsy. So at birth, nothing is moving. You see it about 10 days, something starts moving, and that's good. So incomplete palsy, you find some clavicle fractures on the same side, it's okay. Hand and the fingers moving, fine. That means, you reassure them, it's good. But then clavicle fracture on the opposite side, phrenic nerve injury, breech delivery, I think we feel is bad. They don't really recover, But then they're all not definitive. It's only idea. And it's only for us. It's not to tell them, So that's what we do. So what investigations do we do when? I think that's the next question. Whenever we find children, they all come with X-rays, MRIs, nerve condition study, EMG and all that. But actually, we do not do anything. We only serially do a good clinical exam. It takes time. We do a good clinical examination and document. Every time we come, we have to document. This is working, that's not working, like that. We investigate only when we think of surgery. Because at that time only we do surgery. For example, serially investigate. How do we examine them is a question. No? See, this is what is called as a tickle and towel. No? So if you touch the child, if it's going to work, they immediately bend it. I think that's one of the things that you do this like this, you do like this, then what will happen? Then they'll start bending. You do here, I think what will happen is they'll start bending here. So that's the state of the do. And the next thing is, this one of the things which we have written up now. You child suddenly put a towel on the face. Okay, you just try to any child. Immediately they throw it off. Okay, but then if you hold this thing, you see this child, you put the towel. Okay, we not done anything. No? So the maximum that the child can do is this. The adults, we can ask them to bend it, all that you could say. No, for a child, you just have to put the towel. And if you don't have a clean towel, just keep your hand on this. So this we have written it up and published in the British Journal of Hand Surgery. It's a very extraordinarily simple way of examining a child. Okay, and what do we tell the parents? What do we do? We tell the parents, the child, you must move the joints and the movements which the child is not able to do. Suppose the child hand is pronated, you do this, bend it. It's not going up and do this. I think this is exactly what we always say. One is supinate, flex, externally rotate, and take it big in that. And you do it 10 times every time you feed the child. I think that's it. No need for splints. I think that's not it, because splint means that they get very worried. And this is the best thing that can do. So the timing of surgery, I think this is the first part of the talk. If there's no hand function, that means a global palsy, 6 months. You cannot delay it. Okay, you see a child, no hand function, hand is flat, nothing is working, that means it's if a good hand is there, elbow flexion is allowed, not there, around 9 months to 1 year, I think that's right. I think that's what we would say. Neural recollections are most useful because if you leave these children, they get nothing works. But whereas if you operate, not that they become fantastically good, but then they get better results than what would have happened if you're not operated. I think that's what we would say. So the 3 months is a good child. So we do this. We put a lot of nerve grafts in say 6 months old child. Usually you get 5 and 6 roots usually are available. The same child 5 years afterwards. So this is the child 5 years after this much has got. And then we do some surgeries on the shoulder muscles so that they become better. So that's what that's what we will do. So that part. So the hand starts now working, little bit working. So you see 6 months, no elbow flexion, good hand. So usable proximal stamp. So again now we do a transfer, results at post 3 months. So now we come to the second group. These are all children has to immediately see, and these children whom we operate, they not that they become fully normal, but then they will have some amount of it. And what do we do? I think that's what now we do. Basic main problem is they go up to this and they don't go fully, and they have an internal rotation contraction. So when they get to the hand to the mouth, they go off like this. They'll be going like this. So what we do is we do it on the muscles. You see this child is a child. You find this child, there's tight muscles are there. You try, the other father is holding and see this not moving. You always see like this. So what we do is we find that the nerve muscles are good, but because of the co-contraction is not moving, we release one group of muscles. See here we release all the contractures, pec major, latissimus dorsi, and all we contract. And the same child. So you see the preoperatively how it is, and for 4 months later, the same child. Okay, yeah. See, the best thing is that they don't really do this. They just think these are surgeries which make parents very happy. These are children they're all chocolate cases. They are all good cases. Yeah, 2 years child. Okay, 6 years follow up. Same child 6 years later. You'll still find the movement is good, but you see this hand here, and you see the size here. There'll be a mind difference, but that's acceptable. As long as they do well, they are happy. So there's a preoperative and the postoperative to 1 year. And most important is, for a girl child, this is very important. They don't go back. If they don't go back, they can't put the ponytail and all this. Say for our Indian girls, it's very important that child hand goes back. So this surgery makes it go back, and parents are very happy. The next problem they have is that when they go to eat, it go off like this. So that's because the shoulder doesn't externally rotate. For example, all of you could try if you like to eat. The first thing that happens, moment happens, is not in the moment. You see the shoulder is moving out. If the shoulder is contracted, then what happens when you lift? It will come out like this. So that produces a lot of deformities. That produces. We investigate now. We investigate at this stage before we operate. The same child. It's a preoperative this child and post-operative. I think the same child how badly it was eating, and then now it will be eating. You will find the child is not able to rotate, and now this child is able to rotate. This we do it at the clavicle, scapula, at this level we do. And the other alternative we can do when we see older children, we do at the humerus. We slightly cut and turn the humerus. You see the same child, post-surgery, you will find how she was. They see how they look, internally rotated. You see the hand and how it lies down. When they walk also is good. And they eat, so eating like this. When they go, the hand, the hand goes like this. So this is the same child, hand, after this thing, they're going up, and then they go to the mouth. I think this is very important. When they go to the mouth, they go very well. So lack of supination. Some children, this is the deformity at the shoulder. Sometimes we analyze what's the other problem. They have some forearm deformities. We just understand as to what do the parents want, what does the child want. Okay, and then tailor-made we do. So this child, the parents were extraordinarily upset. They're upset from birth. They were telling, they're upset. One of the reasons Stanley says when she goes to the temple, she's not receiving the prasad. They says the mother says, I feel very bad to go to temple. The only thing we did was a small osteotomy here, and we turned off the forearm. Okay, then what made her parents happy is that now when they goes to the temple, the priest doesn't scold us for keeping it like this. Okay, so that's what happy. And the other people, sometimes the children come up like this. Their hand like this. I think when we walk, nobody walks with the palm in the front. So that again makes people think bad, So there again we do some osteotomies, we do that and do. And finally the last two slides tell us about when everything is lost, nothing is possible to do. What we are now doing is we used to do it in trauma. Now we are doing it off in brachial whisper. We take the gracilis from the thigh with the operator nerve, the muscles, the arteries and the vein that are supplying the muscle, and take it back in anastomose here and attach the nerve to the spinal accessory nerve or the intercostal nerves, and then make the child. So this is what the gracilis muscles and the nerves that we take, and we take it over there and attach it so that they are able to bend the elbow. So to summarize, so I think we'll have more discussion. When a child is born, there's a lot of concern. I think it's very understandable because nobody expects it. I think what we really need to do is to be calm, and child need not be sent far for referral. So that again makes them very upset. Now take a 10-day-old child and all to hundreds of miles, and then we say nothing need to be done. Okay, so that makes child need not be sent far for referral. That's one. Number two is no investigations are needed at that stage because many children have MRI. And if you have to do an MRI in a small 1 month or 2 month old baby or a newborn, it has to be in general anesthesia. So that again puts them off. So what you do is reassure and gentle physiotherapy and review. What physiotherapy? Do passively all the moment that the child is not moving. I think that's what I say. You do that. We always tell them, you do this. If they say, doctor, the child is not bending, then you tell them, you bend it. Child is not taking it upstairs. Okay, you take that. Okay, that alone you have to do. And do it 10 times, each time you feed the child. Okay, so that again is a very good instruction. Otherwise, they'll keep on telling morning 2 times or evening times. You tell them whenever you feed something, you do. Okay, that again makes it. So when should the patient be seen? I think that's by 3 months. Whatever it is, whatever type of recovery happens, by 3 months we have to see. Because at that until the time we don't miss anything. So definitely by 3 months if there is some weakness. Okay, even if it's good, we can see it by 3 months. Then we can some small things, refinements only. If there is weakness, definitely we have to see by 3 months. And at any age, we can see to find out whether there are procedures on muscles and joints where we could improve function. So to summarize, if you have a hand that is paralyzed, I think that's the take-home message. The hand is totally paralyzed 3 to 6 months because there is a window of opportunity to do something good. If that's missed, that's missed forever. You've got a paralyzed elbow and shoulder, 9 months. Okay, after that, you can just leave it. If the hand is good, little more time. The hand is not good, we have to see it early. So most of the children, 80% of them recover very well. Okay, any child who has not recovered well nicely in 6 weeks might need a surgical procedure. Paralyzed hand, early nerve surgery, 6 months. Paralyzed elbow, shoulder, 9 months. And timely secondary surgery can improve function. And we feel now there's a very good group to take because you need to really talk also a lot of things. As much as operating, you need to really talk on these children, and then they do very well. Thank you so much. Thanks for the opportunity given us to meet all of you, madam. Thank you so much.